Hello, everyone. Good
Hi,
morning.
Jana. Good to see you again, and I'm glad that you have a good connection and we are all here in the room. So again, thanks for joining this parallel session, and thank you so much, Francisco, for being a moderator for us today. I'm Francisco Nuno Rocha Goncalves. He's the head of market access at Sanofi, and he's going to take the lead from now on. The floor is all yours, Francisco.
Thank you, Paulo. Thank you, everyone, for being here. It's indeed a great pleasure to moderate this session. This session is on the use of data. It asks, or it raises a lot of questions that I will address our guests today. Hopefully, you'll be able as well to set some of yours. How do we use data? We've been focusing on the quality of data and registering data. It's now time to ask users, how do they use data? And also there's a secondary question on this panel, which is, what's the role of users in defining the quality of data, whether they should passively accept the data as it is presented to them from secondary databases eventually? What's the role? And having been, before my role in Sanofi, have been on the side of hospitals as well, and very much concerned about collecting appropriately data. It's also been about what's our role in defining the proper data sets, the data we are to collect, the data we are to register, and how are we going to prepare it for the research questions we may have. So next to me to answer these questions, and especially to address some of their experiences, I have NadirAmmour, global lead for Sanofi on clinical innovation and partnerships. Remote, as mentioned, we have JanaMakedonska, Program Manager in the EuropeanHealth and Digital Executive Agency. And then we have MarkLittle, Professor of Nephrology from Dublin, from TrinityCollege. So welcome all of you. I will start on this order, which is the order on the program, nothing special. How do you see this? How can we best use data, Nadir?
Well, thank you. Thank you for having me, and thank you for inviting me. So I think we need to start with, fundamentally, research has always been powered through data. I mean, as we started to develop evidence for generating insights and improving that, data has been and is and will continue to be critically needed for that. Now, I'm working in clinical development, so our job is really to design the studies that would be, responding to the questions required for filing a new drug and filing an application. So we are using the gold standards of randomized clinical trials. So we decide which data needs to be collected. We put a lot of effort and resources in establishing the, the study protocol, designing the database for collecting the data, and we essentially create the data that we need for the generation of the results of the study. So that's really how the clinical development is doing. Now, the questions is, with the availability of data that is collected as routine practice, how this data can be reused for research, and how this data can be reused for being part of the evidence generation package that is needed for regulatory agencies to review the filing and support it, and for HTAs. So there is a lot of tractions and interest into leveraging this data and leveraging data correctly collected. The data quality is really one of the dimensions that we need to work all together, and maybe we'll have some questions about how data existing can support drug development.
Very well, thank you, Nadir. Jana, your view on that. How can we improve the use of data? How can you use data that exists or improve the collection of eventual novel data sources?
Mm-hmm. Thank you for this question. As I may say a few words about the entity I'm working for. So I'm working for an executive agency that was founded by the European Commission. This is the European Health and Digital Executive Agency, which manages funding programs on behalf of the Commission, and my unit focuses on following projects and organizing evaluations for Horizon Europe and following the Horizon 2020 legacy. So we look at the way our consortia, collaborative research projects, address data quality, and what we have observed, looking especially in the past decade or so, even before that, is that since most of the times we do not have specific requirements for consortia on outputs on data quality, we don't have this information on our side very often. However, if we specify this in the calls for proposals, we actually see very interesting outputs that we are pushing for, that are related to the realization of the European health data space, such as working towards standard data quality frameworks across, not just across academia, but we have projects, especially lately, that also involve HTA bodies, regulatory decision makers, in this consortium, of course, SMEs. And we also pushed quite recently in the context for the HTS, another topic which actually develops innovative solutions to improve the data quality and many aspects upstream. I have a presentation on that if we go to that stage, but these projects have not yet delivered. They have just started, so this is fairly new, and we see quite ambitious results in quite ambitious ideas about monitoring the data quality throughout the cycle, or real life quality checks at emergency departments, acute medicine departments, with voice controlled assistants, or the kind of artificial intelligence powered virtual assistants that help clinicians and also patients, in fact, follow up on their data. So I hope I answered your question. Our projects are quite multi-dimensional, so it would be interesting, I think, for the panel to also see what they're doing in practice. I'm not going to say more at this stage. Thank you.
Thank you, Jana. Mark, you're not just an academic, you're also a clinician. So I guess you have a role in the whole pipeline. I mean, defining the research question, making the appropriate registries, and eventually being a user of such data.
I do. I straddle all those three dimensions, and I have made some slides. I'm not sure if we're going to come on to those or not. This is just an introduction. Okay. I think the discussion in the last session about, pushing us back to the actual physicians and the people who are entering the data at the source is absolutely critical. And as one of those people I'm in the space of rare diseases. So we operate really with registries, data registries, and these require a lot of input from the local clinicians. And I understand that when you ask people to do that through their day job, it does not happen. It just does not happen. And what happens is you get garbage out at the end of the day from the registry. So it's, at a very high level, how do we address that? Well, we need to, definitely include these people as active participants in the research. That's one aspect. They have to kind of see what they're going to get out of it, the clinicians, not the researchers. And also we need to merge that with ways to handle this, basically using analytic techniques and data quality procedures to understand where the data quality issues are and to mitigate them using technical solutions.
Very well, thank you. So now that you know our speakers, we can move to the presentations. Jana, shall we start with yours?
I got muted, so yes, my pleasure to start.
So I'll ask the technical.
Okay, so you have my slides. They're going to share them, or should I share them?
It's not ready.
Okay.
Jana, I think you're supposed to share them from your side.
Okay.
Correct? Yeah. Okay.
We have not agreed, but I'm ready to share them. So that is perfect for me. Let me just get the right view. Screen one. Yeah. I think this is screen one.
Okay. It's on.
Can you see them?
Well, very well, Jana. Thank you.
Okay, I'm going to maximize the view. I hope you can see. Well, you don't see the right view, so I need to disconnect, I think, one of the monitor. I suppose I need to disconnect it. The thing is, I'm connected also to the internet through the same cable. Now, normally it should have worked because the monitor is off, but you still see, I think, not just the first slide, but also the next slide, which is not the ideal situation. Is it still okay for you? Is it big enough, or how should we do that?
It's very well. It's very well.
Okay, so then I can start. Very well. So I presented myself already. I'm not going to dwell on that. It's a pleasure to be here, and I hope that we can engage in some interesting debate following the presentations. I work for the European Health and Digital Executive Agency, which manages on behalf of the European Commission a number of programs. It's a new agency, so you may not have heard about it. It was launched in April 21, actually. So this is more or less the budget distribution per different programs, and my unit manages Horizon Europe Cluster 1 on health, and as I mentioned, Horizon 2020 legacy programs. But you're certainly aware, apologies, you are certainly aware of the EU for Health program, which is responsible for the management of the joint action. Well, it is the one that published the joint action on the European Health Data Space status, JA, as we call it, and also which is behind the EHDS pilot for secondary use of health data in research, regulatory decision-making, and policy-making. Now I'm going to draw on my experience mostly in Horizon Europe. I have sampled the programs in the agency, but I still think our programs are the most relevant to this question. And I'm going to be talking about projects, new projects, which have just started, so this autumn, or are about to start in January, and the way on data quality they do. Because as I mentioned, though data quality is a must, and it is certainly addressed by our collaborative research projects, oftentimes we don't see the outputs unless there is a specification in the call for proposals which requests a specific aspect of the scope, a requirement to be a deliverable, an output on data quality. Of course, data quality is ever more important when technology advances and artificial intelligence aims at and is processing and integrating large quantities of different data types, also novel data types for a specific use. So it is clear that this is an important aspect that needs to be tackled. Now, looking at the two relevant calls for proposals that resulted in very interesting projects that address data quality in some ways, one of them is innovative tools for the use and reuse of health data, in particular electronic health records and or patient registries. So we are funding 5 projects out of this informal cluster. We call it the Into EHR cluster, about 8 million each, so for each project. And indeed, all of these projects aim at developing novel solutions that would improve the data quality, but also data interoperability, machine readability, and reuse of health data and also metadata. And they also focus on natural language processing tools to improve accessibility, transcription, translation, interoperability of the data. And one of the cornerstones of this topic is actually taking unstructured health information that sits in clinical and medical databases and bringing this in a structured form into EHRs and or patient registries, depending on the focus of the project. And all of this is getting actually included in an AI-powered virtual assistant or assistants that are one of the main outputs of these projects. Now if you look at the projects in specifics, ECRIM, for example, as I mentioned in the question that was asked, is about enabling clinical research in emergency and acute care medicine through automated data extraction. They focus on a number of interesting questions tailored to the needs of the emergency departments, such as processing these notes that are written in haste by these professionals who take care of these patients, develop an IT system that actually captures the data contained in the EHR in use in the emergency departments, integrating this data with data sets from administrative databases, and in the end, develop an EHR for emergency departments fit for the actual needs and test and validate these solutions in 2 use cases. So this project is coordinated, for your information, from the Mario Negri Institute, and the work on data quality they do is actually embedded in the virtual assistant, which has a decision support module, which provides real-time validation of data quality. So it is basically guidance and alerts to the people entering the data in the health record, to be it about capturing, detecting some kind of inconsistencies in the data, what they call also implausibilities or incongruences, like the acceptance date is post the release date of the patient, or even alarming situations about prescribing drugs, given that allergies are known. So this is ECRIM. Now, if you look at another another project, IDAVA, coordinated from the Maastricht University. It focuses on the AI-powered data curation and publishing virtual assistant. So they want to really focus on automating verification workflows, extracting structured data from narratives, developing a semantic data model for this structured data, and having this personal assistant, which is really about individual curation more than about mass curation. And they have two use cases to actually validate this whole setup. One about personal longitudinal health records, so that's something you may have heard about the concept, and work on hospital registries into the therapeutic areas. So they focus on breast cancer and cardiovascular disease. And the work they do on data quality is they want to do data quality enhancement through their IDAVA prototype. They want to have a structured process for the automation of this aspect and compare the data at the source with the enhanced data that their prototype is actually producing. Now, these are the two use cases, just to mention. Another interesting project focuses on rare cancers. So this is coordinated from the National Institute for Tumors in Milano, in Italy. It's called Idea for Rare Cancers. So they focus on governance, sharing, the classical thing in local and federated context. And what they're doing in terms of data quality is they want to have these model building services for federated data analysis that monitor and also audit the data. And they have a tool that they call Multimodal Data Navigator, which checks the data quality for the data before it enters a specific analysis, which is also important. I think the relevance for a specific analysis here is tackled as well. There are other projects. I'm not going to dwell on these. They're quite ambitious, but sometimes at this stage a bit unclear on what they're going to do in terms of data quality, such as the Rescue Plus project, which is really about automating this data entry tool that is of the global initiative. You may have heard about the registry of stroke care quality, the so-called Rescue, and they just say that they want to contribute to EU standards for data quality. And data tools for heart, which is again a very similar project focused on cardiology, developing a number of things such as federating learning toolboxes, a tool for data synthesis, NLP tools, and it is their data ingestion tool that actually will include curation mechanisms to improve and quantify data quality. And I quickly wanted to touch upon another set of 5 projects that came from another topic. So they're not yet signed. I'm going to just mention the general objectives of these projects and not mention them in detail. So the previous projects focused on clinical research, clinical decision making. Here we are talking about regulatory decision making and HTA. So the topic was, or the call for proposals, new methods for the effective use of real data and/or synthetic data in regulatory decision-making and HTA. What was the purpose? So we want an expected outcome in a few years down the road, following the end of the project, that these bodies adopt optimized data-driven methodologies for the effective use of real-world data and/or synthetic data derived from digital twins or advanced computational models for the assessment of medicinal products and/or digital health innovations. So all of these projects are working towards the following. So first, develop evidentiary standards to be used in the analysis of these data for these purposes. Second, interesting for this audience, work towards a standard data quality framework for these data types and for these uses. Then defining methodological standards for the regulatory acceptability of real-world data and/or synthetic data in the context of clinical trials augmented with this data. And of course, develop ML methods to help process and analyze this data for these uses. So as I mentioned, 5 projects, 7 million each, and they tackle quite a few interesting aspects. And I'm going to briefly touch upon these, such as an AI framework for assessing real-life effectiveness of novel cancer therapies, or investigating how real-world data can complement randomized clinical trials to improve the efficacy, safety, and value for money of technologies to prevent and treat diabetes, or just the use of registries in this context, or something that I found quite interesting, creating an ecosystem that brings together a collaborative framework that brings together regulatory decision makers, authorities, but also application developers, healthcare professionals, and policymakers to have a transparent ecosystem and dialogue on the evaluation and certification of software in healthcare. So all of these projects tackle data quality frameworks, as I say, and one I found quite interesting, which is planning to actually develop an end-to-end methodology and standard operating procedures for introducing systematic data quality control in hospitals' real-world data processes, something that we touched upon already. So all of these topics include national competent authorities in one way or another. This was a requirement of the topic, and several of them intend to have a close dialogue with the EMA and with the Darwin EU that we heard about. So these projects are starting in January 23. And with this, I would like to thank you. Well, this is something else I can mention, another program that is not in HDEA. Well, it's partly in HDEA, Digital Europe program, which supports also infrastructure work, which is co-funded between the member states and the Commission. And though they don't have specific requirements of data quality, certainly they're going to tackle these. And these are the two topics, so federated infrastructure for genomics or for cancer images data. With this, I'd like to thank you for your attention, and when the time comes, I'm happy to answer any questions. Thank you.
Thank you, Jana. We'll certainly have you in a final round of questions and comments, okay, after the main presentations. Mark, shall we? MarkLittle from Trinity Dublin.
I use Prezi, so it always is a slightly nervous moment.
Not at all. We're very much welcome and eager to listen to what you have to share with us.
Okay. So thank you very much. I'm from TrinityCollege in Dublin. I'm a clinician and an academic health researcher. So the question here is, should research users passively depend upon the quality of the data they can get? And I stand here speaking to you as somebody who really uses this data in their day-to-day research activity. As mentioned, I'm in the rare disease space, and I'm going to use two concrete, quite granular examples from my work just to demonstrate that the garbage in, garbage out concept of using health data in when you're trying to develop analytic tools. So I am in the rare disease space. So particularly, I'm interested in rare autoimmune diseases. So when you look at rare diseases, you really need to think about registries. And this is a registry that I'll refer to in this talk. It's from a small country, a relatively insignificant country off the western coast of Europe called Ireland. And we have a national registry called the Rare Kidney Disease Registry. And my particular area of personal academic interest is in this disease called ANCA vasculitis, which is a rare relapsing and remitting autoimmune disease. And our research basically focuses around one particular question, which is personalized relapse prediction. So can we use data, multimodal data, from the electronic health record, the registry, and from biomarker work to identify people in whom we can predict relapse of the disease and therefore inform our treatment strategies that I will implement in my clinic every Friday. So the question here for us is, how do we measure relapse, or how do we identify relapse even in these data sources? And there is a standardized tool for this called BVAS. It's Permanent Vasculitis Activity Score. It's used by everybody around the world. You will not publish anything in this field without saying we did a BVAS score. So this is the way we identify these in cases. But of course, in a perfect world, you'll have endless time and money and lots of staff. And these tools need some training to implement correctly. You'd have everybody trained perfectly, and you'd have 100% accuracy in identification of relapse. In a real world that I operate in, there's obviously resource limitation. These humans make errors. They're not always certified for doing this scoring system. The BVAS scores are not entered correctly, so we get events incorrectly identified as relapse or not identified at all. So the relapse concept or the relapse event is around which all of my research revolves. So if we get that wrong, the whole rest of the house of cards falls down. And just a little bit of data from this, when we looked at in this national data set, we manually adjudicated, went into the primary records of all the patients, and we said, okay, well, was that a relapse or was it not? And then we compared this to the BVAS score entered in the registry. And to the left of this line here, on the x-axis here, this is the score that was entered in the registry, the BVAS score. And if it's 0, that means it's not a relapse, the patient's in remission. And you can see that there's 0.7% misclassified in that case. So these are people who do not have a they don't have a relapse, but they're inappropriately identified as having a relapse. And on the x-axis to the right of that line, these are people who received scores, positive scores indicating that this was a relapse. And when we went in there, we found that about 37% of these were misclassified, i.e. many of them did not have a relapse. So that was the real kind of issue that we came across. So the question is, how do we deal with that? You know, that's the end of our research, basically, if that's the kind of data we're getting. So the answer is, which relates to the technical approach that I mentioned, is to use the existing data to fill in the data quality holes in an intelligent manner. And I've got a PhD student called Jennifer Scott who's doing work on this, and this is an alluvials plot saying, okay, well, what are the components of that relapse? When you look at the real world data, what bits make up what we call a relapse? And without going into the details of this, we've got an antibody level, we've got suggestive bloods, we've got suggestive imaging, we've got what happened to the immunosuppressive drugs, what was the response to that change in immunosuppressive drugs. And she has kind of linked all these together and developed a model that tries to attribute the presence of a relapse or not. And when she uses this model and compares to this, the adjudicated probability, she gets very, very good separation and very good accuracy in terms of identification of these relapse events. When you have a definite or a higher probability relapse, there's a little bit in the middle here, this blue one here, where we're not quite sure, even when you look at the primary data, and they're quite messy, and we tend to just exclude these from our analysis. But, you know, we really identify the no's very well and the yeses pretty well as well. Also, this assumes, of course, that you have all of those components within your data, and that it's, you know, there's no missingness in it. This is obviously not the case. So she developed further models to say, well, if we take out this bit, what happens? The accuracy of the model. If we take out this and this bit, what happens? So as you go further to the right on the x-axis here, you get increasing missingness, and you can see what happens the accuracy of the model when you do this. And this kind of more accurately reflects what happens in real life when you are missing little pieces of the data. And it just gives you a bit of clarity on the certainty you can have in terms of attributing a relapse. Second example is from a European project I run called FAIRVASC. And again, this is using registries, but here we're trying to take these individual data sources because, you know, these are rare diseases. These individual registries themselves are not really big enough to make any proper inferences. So we're linking these together using knowledge graphs and RDF-linked data graphs to create a federated analysis framework, a single point of entry dashboard to analyze aggregated data. So we are really quite at arm's length here. We don't get involved in registries here at all. This is, you know, they are managed themselves. We don't have anything to directly input into them. So we, of course, one of the things we do with this is we have a data quality report across the data sets. And this kind of gets, again, a little bit depressing. You know, we do pretty well when it comes to consistency and plausibility, but when you get into completeness and looking for missingness of data, you know, you start to see on the bottom here more Manhattan type plots with, you know, tall buildings and short buildings, and sometimes no buildings at all. So you can see when you kind of start digging under the surface of these registries, when you're trying to map them onto a common data model that we do, you know, it's really quite difficult when you're missing a lot of the data. And so this is a real challenge, especially for rare disease research, because A missing data field basically means that case is excluded from the modeling, and every case is precious when you've got a rare disease. Unfortunately, these are usually not missing at random. They introduce bias in the data set, and they're incompatible with most Python libraries that are used in machine learning. So, of course, there's various methods of imputation, and I'm sure there'll be lots of discussions about this. But I think, having tried this a couple of times, as a clinical researcher, imputation doesn't really work very well for clinical data. That's what my kind of sense of it. We find that, if you really go down intelligently and develop specific algorithms that can fill in little pieces, for example, this one here, where we've got a longitudinal timeline for a patient here, they're in remission, they're in remission, they're in remission, missing data, remission, remission, remission. And if nothing else changes in the middle one, we just put in remission, so it's hard to have those as automated algorithms, but you can design it in such a way that you can fill in individual little pieces like that. And that gets you some of the way. But in reality, it does come back to the source data. Passive acceptance of this data leads to garbage research, in my experience in this rare disease field. So how do we get that better? Well, as I alluded to at the start, we need to consider the people who are controlling those individual data sets upon which we're relying as active partners. We need to engage them, show them how it's a benefit to them, include them on the papers, include them in the research, not just kind of sit back at arm's length and just say, yeah, we'll just use your data. Thanks very much.
Thank you so much, Mark. Okay, from Nadir, we won't have like a PowerPoint presentation. I do have some deeper, more thorough questions for him. He will address them so you can listen to his opinion or to his views on quality of data. And also on the second topic, when doing research, we have to be very efficient. We have to be very assertive about, well, not just at the moment where we design the research questions, but also when we look into data, when we look into the structures of institutions on the data sets and how can we relate different information blocks. So I would summarize that with the agreement, of course, of Nadir on the topic of core data sets. And I would like to hear his views on that.
Yeah, thank you. So I think and thank you for both presentations. I think it highlights the challenges and the complexity when we are going into an area where we want to generate insight that are supporting, policy decisions, regulatory decisions. And at the same side, there is, when we talk about healthcare data, there is a vast amount of data. I mean, when we talk to our hospitals partners, when we engage the dialogue with them and say, we plan to use the EHR data for some research. If you're sitting from a hospital perspective, electronic health record is several databases, contain different type of data. They're all scattered all over the place. And one of the projects that we have managed a couple of years ago was aiming in oncology to operationally eliminate a simple situation. When you are running a trial, we have data entered into the electronic health record as a source data, and we are asking the physicians and the study coordinator to re-enter that into the study database, which is the case for registries in certain instances. So we looked at how can we eliminate that manual transcriptions that comes with errors and comes with issues and delay the result of the study, create job that is not very attractive, and you cannot fix those manual entry errors, actually. So we designed a project, and the questions was, we worked with 4 hospitals in Europe, and the question for them was, how are you going to do that? I mean, you are different sponsor. We were 4 sponsors at that time, 4 hospitals. And, we run different type of indications, oncology, immunoinflammations, neurology. And from their perspective, it was too vast to be able to address that in an 18-month project. It was really 2 years project where we had set the objective that by the end of 2 years, we have demonstrated that there is a percentage of data that can be collected electronically. The way we have addressed that was essentially to take away one of the assumptions, or at least thinking mindsets, that I face every time we discuss this aspect is you cannot define what is the data needed for research. Questions are endless in research. However, if you take specific angles, you can identify that there is very commonly the same data collected across research. If you look at drug interventions, most of the data, the larger volume of data that is collected is about safety. And if you point about safety, it's all around how the drug is being metabolized into the body. So you will always have, safety laboratory data and other procedures that are irrespective really of the drug. You have, renal functions, you have liver functions, or blood counts. And when you do the calculation, and this has not been really done, I haven't seen any publications on what is the, distributions of data collected in research and what data are very commonly collected across, very large pool of studies. So we've done that analysis. We looked at 120 trials, and what we found out, and there is approximately 60 to 70 procedures that will be collected across studies and across sponsors. So 60 to 70 procedures immediately, relax the anxiety of the people who have to manage the data, because then it becomes an achievable target to map them out, convert them into common standards, apply data quality measures, and focus on them and address at least that bit of data. And what we found is those 50 to 60 data points represent 40 to 50% of the data collected into a study. So I think what we've learned there is two things. Is number one, we can, and if we do the analysis of data commonly collected across studies, we can identify core data that we call high-value data sets. They're not all those data that we collect. If you are collecting, maybe one endpoint that is only measured 3 times in an 18 months, it is not where we need to start. We need to start in those data are collected, every day or every week that constitute a larger volume of information. So this high volume core data sets in oncology has been designed, and we have been working on that. I think there is it's available. We're going to have publications coming out very soon on that. The second aspect that we have, found out is the hospital are telling us, we relax. If it is about this data, we can start somewhere, actually, because that's the point for them. Where do they start? Do they start from a project basis? I have this specific study and I'm going to focus on that data. Or can I start into some generic components that we can develop and enhance significantly? And across the 4 hospitals, not all of them have all those data, but each of them have said, okay, great. Now that I know those data, I will be able to put them out into the ETL and whatever data processing that we have, and we'll be able to manage that. Another example that we had very recently in AMI project is called EuropeanHealth. It's in NASH intervention. So that is a different type of situations. We're looking at how can we identify patients that could be, joining a trial by, analyzing the data. So we spoke to the NASH team and they were telling us, what is exactly the context? Yeah, we are a year ahead of starting the study. We try to develop the network of sites that will be participating. We want to check how many patients are, potentially, enrolled by each of the sites. So instead of only asking the investigators, and no comments on that, and investigators know that, but there is also the fact that as an investigator into a hospital, you don't know all the patients being seen there by other colleagues in other services. But if you browse the data, you may surface patients that you're not aware of that could be, eligible there. So we sit down with the NASH team and they told us one of the challenge, if you try to get this number a year or maybe a year and a half before starting the study, is the primary criteria is liver biopsy. And we do liver biopsy. Any study in NASH would have as a diagnostic liver biopsy in the 3 months prior to getting into the study. So if you're doing that ahead, 1 year ahead of time, the 3 months doesn't work. So the question was, how can we find proxies before we can, we could go into the question about that, I think that we mentioned, what proxies can we find with that? But the interesting discussions ended up with the pathologist where he said, well, we have maybe 10 data points that if they are systematically collected, will increase significantly the ability to use the EHR to find patients. And he was ready to discuss with their, medical EHR systems and team to design a form where every single patient, at least those 10 data point will be entered systematically by any physician seeing a patient into the service. And he was also saying that's probably something that we should publish and have the International Society of Pathology to be presented there, and maybe develop that as a general practice, where from a physician perspective, 10 data points is not that much. We cannot ask more than that for the question that you've raised. I mean, there is no incentive to collect this data. The people entering the data, I mean, do not have time. It is not really something that they understand that's going to be very valuable. But 10 is manageable. I mean, if you only have 10 data points to be managed, is something that is manageable. So I think the concept of a high-value data set responds to, number one, let's do the analysis. Let's find out what are the data most commonly collected. Let's make sure that we qualify them properly. And we share these informations. We can publish on that and share these informations so that everyone can focus on the starting points from where some value can be generated for research. So to respond to the questions, should we be passively, we're using the data? There are techniques to do that, but we should not be just waiting for the data to improve by themselves. They will not improve by themselves. They will improve because actions will be implemented, and communities will be working toward recognizing that it is not a question of a single organization. It's a question that spread beyond the researchers themselves. It's also the clinicians, the nurses, the study data entry people at the hospital. And then we need to create the incentive for that to increase the quality of the data. So I think there's a way to go there, but to go back to the point, the high-value data set was a way to get the catalyst components to move forward with that.
Perfect. Now, thinking of some of the attendees of this conference, a rather general question for the three of you. I have the notion that a lot goes into the what we factor in when selecting partners for research projects, but still, we're in an academic center within the Faculty of Medicine of Porto, within San João, but there are so many others in Portugal. So to our guests, what do you expect from us? What do you think we would have or we could show if we haven't yet, so that you could consider us as partner in future projects in whatever area? I mean, I'm keeping this deliberately broad so that you can approach from any perspective, be it the HR competencies or be it characteristics of data, diseases, etc. Shall I start with Mark?
Well, obviously not from a trial perspective necessarily, but for big observational consortium studies. And, Jana, I applied for one of those grants you described earlier on, and sadly wasn't on your list of things you described. But I kind of do quite a lot of these consortium EU applications. And so there we're seeing, okay, where are the partners, and we have a very specific high value data set that we'd like to get. So the really thing that identifies people, is their expertise. It really just is their expertise. They're standing within the community. Their belief in collecting data. Their value, the value they place on it, and the fact that they've demonstrated it before. So it's really their expertise. Yeah.
Very well, Nadir.
Yeah, I think I will echo what you said. I mean, the expertise is definitely one of the area. The willingness to address those issues and tackle them, which means also that beyond the expertise, there's already some thinking around how to address that. Because I think there is multiple dimension, as we've heard about that, and I think those partners who have also some ideas about how to move forward with that would be also very beneficial. And finally, I think the data, because we should also, when we look at that, we also look at what is concretely can be brought into the consortium that can help accelerate or increase the success factors of the objectives that is being looked at. And finally, why the data and the expertise is required. Because in my opinion, consortium that are formed around these topics should really go beyond the theoretical exercise and get into outputs that are reproducible and can be spread all over the place. I mean, one of the things that I found in consortia as a weaknesses is there is a lot of issues with consortia getting to its ends, and all that knowledge cannot be reused and cannot be get into novel practices that the general community can embrace and use.
Very well. And Jana, would you add something?
Yes, thank you. I think Nadir truly touched the pain points that we see in our collaborative research projects. Indeed, if you look at the projects I mentioned, very often the technical data expertise comes from the academic partners, very often. Sometimes actually clinical researchers are in the lead of consortia. This happens as well. Or on one occasion, we have national regulatory agency who is also leading a project. That's more unusual. But I think it's very important to have, and this is what we promote and ask for, to have some kind of piloting in real life settings of these solutions to kind of try to I don't want to say ensure the take up, this is not really, but to see the value added from these solutions, because one of the issues is sustainability, indeed, what happens after the project ends, and that's why we want to involve more and more either clinicians, as you see in the projects, or the actual users of the solutions beyond clinicians, such as regulatory decision makers and HTA bodies, being parts of the consortium, participating in consortia since the beginning. I think this is very important to develop, because we develop solutions for them in some situations. So just echoing what the colleagues have said on this subject.
Very well, thank you. I could add some more questions to our panel just before we adjourn in 10 minutes, but I will ask the audience and possibly the internet community if there's...
Thank you. No questions so far on Zoom, but please, Zoom participants, go ahead.
Please, one gentleman there.
Works. Okay. So I'm Tiago. I'm a pulmonologist in Coimbra, Portugal. Just one question for Professor Little. Considering the quality of the data, is there a chance to improve this quality and this will of clinicians to enter data when it is useful for clinical activity, as in Portuguese they did in Portugal with the Rheumatology Society, as it builds values and graphs. I always think it would be useful to have a graph of progression of my patients. So if I had something that built that. Just a second question.
I'll take the first one first, because I always forget the second one by the time I think you make a very good point, which I meant to make earlier on, which is that, we feed it back to the primary physicians. We advise them about the quality of their data, how they can improve it, but also we should be feeding the data back really into systems that are useful for clinical care. So as part of the care system, that's really the way that they have a vested interest in making sure it's good quality, if they use it in their day-to-day activities.
Okay, second part, very quick. For the BVASC, is important the quality of the patient's answer. Is there a possibility, or do you do that to teach patients to better answer these questionnaires?
So incorporating patient-reported outcome data into the research is obviously a very big buzz area. Again, massive data quality issues and biases in the data that need to be addressed. And, obviously the whole other challenge of engaging the patient in a meaningful way. Again, in a similar type of approach, they must feel part of the research. They must feel that there's something in it for them as well. Again, they put them on the papers as well, and involve them in the research questions. So how to engage in proper engaged research, that's the key to that, I think.
Well, thank you very much. Now, thinking that we don't do it alone, of course, these are obviously consortiums, and most of those in the room, at least those I know, are used to the idea of bringing in multidisciplinary teams and different perspectives and skills and even nature of investment. One question, how is it like to partner with IT companies? How do you approach them? How do you work the technical side? Because we know most of us, we know a lot about the diseases. We know a lot about the hospital pathways, the proper way to treat patients. We can even come up with the idea of the outcomes, but in the end, we need to work with tech partners. They can be healthcare related, they can be more agnostic and work in different industries. What's like to work with technology partners? Amir?
Very good questions. I think and you're right, there is two, I can split them out into two groups. The one that are coming from other technology or industries and trying to venture into the healthcare, where we usually found that actually they lack that knowledge of the context in which the data is collected and what does it mean. And I think it's a very challenging dialogue, because at the same time you ended up trying to teach someone what is the differences between, you know, very close conditions, but not exactly the same, and why, you know, normal ranges in biology may change depending on the laboratory that you use. So there is a lot of fundamental concepts that are, that could pose the challenge. We usually ask them to make sure that they have someone in their team that will represent that medical knowledge, which makes it much more easier. And personally, when I work with companies that are going to venture in health data, we make sure that these companies have the, you know, the medical knowledge there, and they have a physician that is kind of the scientific director and has made sure that the people involved from a technical side have that background and that knowledge. The second aspect, I mean, I was working recently on a project where essentially we found out that the data engineers were not really expert or not knowledgeable about the specificities of health data. And we directed them to Eden training. So we tell them, okay, go take the Eden training, it's there. And they spend, you know, 4 weeks getting trained on that. They use the Atlas tool, and I can see immediately the change into the dialogue and the ability to understand certain, you know, challenges that we have there. So I think there is resources, and that's fantastic what Eden has done with that respect. And I think we need more than that, and at least we need to publicize that is viable there and direct these tech companies to take advantage of that.
Very well, thank you. Any comment?
I think Nadir said it mainly. I guess what it does need from an observational real world data point of view, you kind of need someone a little bit like me, I think, who's kind of not really expert on the technical side or on the analytics side, but knows enough about it to make sure that the person across the table is not bullshitting you. You know, so understands the debate, the concepts that are required, and be able to kind of speak a little bit of their language, you know. So you do need someone who has a foot in both camps.
Yeah, I relate to that very well. I'll take Jana comments, and then we have one final question from the audience. Jana, please, anything to add?
No, not really. I think the colleagues have a much better insight because they're hands-on in these collaborative research projects. What we see from our side, and we don't like as much, is if an SME gets acquired. Well, it's great for the SME, but as a result, they leave the consortium. And if the expertise is really a very novel, it's difficult to actually fill that spot. But I have no other insight than the colleagues have already mentioned. Thank you.
Perfect. So one final question from the audience, please.
Thank you for self-organizing, dear audience. It's amazing.
Yeah, the audience is.
Well, I think it's working. Well, actually, it's more of a comment and a confirmation of some of the things that have already been said here. I'm a professor, but I'm also involved in SMEs. And one thing that I'd like to share with you is that one of the systems that we have built was on obstetrics. For more than 15 years. In the beginning, we needed somebody like this. Just said we needed an obstetrician. That was a pain. That was always demanding new things, and that was really something that put the project going. Then it happened something really interesting. As we started giving more feedback to the users, and the system went from one hospital to the other, then the number of obstetricians that we had that were demanding things was bigger and bigger. And now it's the whole National Association of Obstetricians that think that the system is theirs, which is great. And so we are being demanded for new things every 3 or 4 months, which is hard for us, but it really makes the system better. And the feedback to the users, it's really something that always strikes me as a very simple feature that normally it's not done properly. And if I may just give you an idea, one of the things that we've made, one feature that was very easy for us to build, is called curricula vitae of the obstetrician in this case, both the doctors and also for the nurses. So each year they can find whatever they did in the end of the year. And it's so simple for us to do this, and this really has a huge impact. So I would say that this is really important. And also because of this, the number of variables that we have now has grown. And so even that idea that most of the doctors and nurses don't like to collect data, well, in my opinion, they don't like to collect data if they don't get feedback. And it's not just doctors and nurses. Nobody likes to do that. Okay, so I really think that we really need to grow the maturity of the systems, and this is how you should do it. Okay.
Very well, thank you. That's a great use case to end up with. So I would adjourn and appreciate very much, especially for the three of you in this panel, for sharing your experiences, and also with the audience for your attention and your questions, of course, will be available certainly in the future, and I speak for all.
Thank you so much, Francisco, and round of applause. Thank you so much. It's really great that we finish on time. Thank you so much, remote JanaMakedonska. It's really to have you.
My pleasure.
Stay tuned now for 13 minutes break, and we'll be back in this main room here for another parallel session. Then the closing remarks from Deepak Karla, which will be remotely with us in a few hours. And then we have an afternoon program with use cases also in the plenary, and finally closing session at 5 p.m. today. Thank you so much. Enjoy a break.
Thank you.
Thank you.
Live stream cortar.